Okay, welcome to this satellite symposium sponsored by Shockwave on intravascular lithotripsy, where we're going to present the latest and greatest data. I'm joined here by Matthew Price from Scripps in San Diego, Akiko Maehara from New York, and Alexandra Lansky from Yale. So we're geographically well represented. And I think what we're going to do is talk to you about the latest data in the concept of the mechanism of action, leave some time for discussion, hopefully generate some interesting discussion and take it from there.
Exciting times. Ziad, let's get cracking. Let's do this.
Right, let's do it. Okay, so I am up first, and I'm going to talk to you about the mechanism of action of intravascular lithotripsy. These are my disclosures. I was involved with Shockwave from a very early stage, so I do have some equity in the company. All right.
Okay, so now this is still the low energy.
The person's voice in the back is John Adams, the person who invented intravascular lithotripsy. This is an egg that we bought from a local grocery store, and we've MacGyvered this Shockwave device, and you can see that we're shocking it from the inside. And we had comments like, it's doing something. Looks like it blew a hole in the back side. What we're seeing on the front side is a membrane. And finally, the eureka moment, I think this is going to work. And we've come a long way. From back in 2009 to 2021, FDA approval in February 16th, over 10,000 cases across multiple hospitals in the first 6 months, outpatient reimbursement, inpatient reimbursement, 1,000 patient post-approval study initiated with the CAF PCI registry, and 1-year outcomes presented by Matt Price, and he's going to talk to us about this again very shortly. There's lots more data coming for IVL. There's lots of outcomes in large real-world data sets that's going to help us understand where we can use it, where we can't use it, what the safety is like in complex lesion subsets. And so there is a plethora of activity as the momentum for IVL continues to grow. And where are we now? We've made iterative changes, and the mechanism of intravascular lithotripsy is something that comes up a lot. It seems obvious, but there's a lot underneath the hood. And so what's underneath the hood is an expanding and collapsing vapor bubble that creates a short, sharp acoustic pressure wave, kind of like switching on a light. This acoustic pressure wave goes through the tissue, hard on hard, soft on soft, and delivers about 50 atmospheres of pressure. And this localized field effect leads to superficial and deep calcium fracture. Now, to understand this, probably the best way to think about it is it started from extracorporeal shockwave lithotripsy. So this is where they have a beam on the outside of your body and shoot this beam into the kidney in order to try to break calcium. And the best way to sort of figure this is it's kind of like a flashlight. So the inside the flashlight, you have the reflector. The reflector collects all the light and then focuses the energy or the light so that you get a hot spot. And that's what happens in extracorporeal shockwave lithotripsy. As a result of this hotspot and the focused energy, the amount of energy that's created is actually very high. And you can see on the right side a typical pattern or graph which shows what the pattern of energy looks like in extracorporeal shockwave lithotripsy. Shockwave is complicated. There's lots of mechanisms of fracture. There's compressive stress, there's shear stress, there's spall stress, tensile stress, and squeezing stress. And all of these come together as a mechanism of fracture of calcium, both using extracorporeal shockwave lithotripsy, as well as intracorporeal, as well as in intravascular lithotripsy. And this little animation really describes the impact. So you have these compressive effects that leads to fragmentation. You have a shear force induction. You get tensile strength and squeezing. And finally, that leads to significant fracture within calcified segments. So what about the technology? What's different about intravascular lithotripsy compared to extracorporeal or even intracorporeal shockwave lithotripsy? Well, the main difference between ESWL and IVL is focus. IVL is unfocused energy, and while it might be counterintuitive, you think, why would you want unfocused energy? You want more energy, don't you? Well, we don't, because we have to get safety before we get efficacy. And if we use very, very high levels of energy, like extracorporeal, which has up to 1,100 atmospheres of pressure, clearly this would pulverize the calcium and blow a hole in the artery. And so it actually took a lot of work to find the right amount of energy to balance safety against efficacy. And you can see on the right-hand graph, compared to extracorporeal, the magnitude of energy from intravascular lithotripsy is much, much lower. Importantly, the mechanism is largely compression stress, although there is some effect of tensile stress as well. What do you need to know? Well, you need to know that there's a field effect. So what you have is you have electrodes. These electrodes deliver energy. The maximum energy is completely parallel to the electrode. And as you go away from the electrode, you lose energy. You'll notice in the M5 catheter, which has a separate electrode that goes to the middle of the catheter, the amount of energy is greater. So you actually may get 75 or 100 atmospheres of pressure. But in the coronary, we're looking at about 50 atmospheres. We get 80 pulses. And I do want to talk to you about the electrode positioning. And this takes into account the field effect or the pulse management. If your balloon's too small and it's away from the calcium, you lose energy as it travels through the other interfaces. So all of the other impedances that it achieves, the blood vessel wall, any soft tissue, that also absorbs the energy. So the bigger your balloon size towards the vessel wall, the closer the balloon and the electrode gets to the calcium. And what you'll see on the left side is that if you get optimal, you're going to get maximum amount of calcium fracture. And pulse management is the term where we actually move the catheter a little bit in order to maximize this perpendicular energy. It's also important to understand what the sizing and the placement of the electrodes is. So in the coronary balloon, there's 4 millimeters from the radiopaque marker of the balloon to the first electrode, then a 6 millimeter gap, and then finally 2 millimeters from the second electrode to the second radiopaque marker. So that should help you understand where you need to place the markers to maximize your effect. Now, what's the real mechanism? The mechanism is this acoustic pulse. So you make an acoustic pulse, it creates this pulse. As the pulse cavitates, it releases a large amount of energy, and that energy goes through the vascular wall and hits the calcium hard. It's important to understand how this works. There are differential effects on different tissues. The impedance of soft tissue and muscle is very similar to the impedance of water. So it's kind of like hitting a hammer onto a pillow. You absorb all the energy. But calcium has a 10-fold higher impedance than soft tissue, and as a result, it's much more likely to lead to fracture, similar to hitting a hammer onto a plate than onto the pillow. This is the rocket science one. So this is actually a very simple mechanism of action. IVL is like a karate chop. It's sharp and brisk, but ultra-high pressure balloons, which also can generate 50 atmospheres, they require a lot of activation force. And so you have a lot of barotrauma that doesn't happen with IVL. Now, we all know that the mechanism of action of IVL is leading to calcium fracture, and we're used to these images on OCT, which clearly show longitudinal axial fractures that get spread out as we inflate the balloon in stents. And we showed this in Disrupt CAD-1 OCT study, and then Disrupt CAD-2 OCT study, and we reproducibly found that OCT demonstrated multiple circumferential calcium fractures and excellent stent expansion. And this is what it did. You broke the calcium, and when you put the stent in, it pushed these tectonic plates away from each other, and you got a big stent. But there's a little more to this story we're learning. Now, a balloon creates a crack due to compression parallel to the applied force. But there are other mechanisms in intravascular lithotripsy. So tensile cracks and shear cracks actually happen perpendicular to the tensile strength or to the applied force. So on the left side, you get the balloon effect, but actually the IVL can have cracks in multiple planes. And on this very interesting slide, you'll see on the left side that you can actually create some chips rather than just axial fractures. And on the right side, you see an OCT where you cannot see a visible fracture, but a micro CT that actually shows a fracture that's difficult to see in the axial plane. So this is a summary of rotational, orbital, and intravascular lithotripsy. And really to summarize, some of the advantages of IVL are you can use your own wire. You don't have to pull a wire so you can protect side branches. It's a balloon technology, so you don't need any special equipment. And so this is one of the reasons that IVL is becoming adopted quickly, because it can be highly efficacious with minimal workflow disruption. So in summary, IVL utilizes electrical energy to generate acoustic pressure waves and fracture calcium. There's no doubt the mechanism of action is fracture of calcium, but those calcium fractures may actually happen in multiple different planes. You should understand the spatial distribution of the electrodes so you can maximize the energy on the wall. And both in vitro and in vivo studies show that this calcium fracture can improve vascular compliance. I think there's no doubt that IVL is going to be an important tool for calcium modification in the future. Thanks a lot.
Ziad, terrific presentation. I always learn things every time we give a presentation. So
That's good.
I have two questions for you. One would be, well, my first question is, and you speak a lot about various technologies. What do you think are the myths of coronary IVL? And are there certain myths to dispel or to confirm?
So great question, because you're setting me up here, because I think many of the myths we're going to dispel in the next 40 minutes.
Okay.
And that is that this only works on 360 degrees of calcium. It doesn't really help an eccentric, and I should be using other modalities in nodules and eccentric calcium. So that's, I think, one of the first myths. And then I think the second one is this, myth about deliverability. I think, in the Disrupt CAD studies, you needed to use some ancillary device in about 30% of cases, but I probably have to do that anyway. I mean, you might use, what's wrong with pre-dilating to be able to deliver a balloon? It's not cheating. And sometimes you need to be able to use a guide extender because we're doing a radial procedure and you can't get down the right. I think this is just part of PCI now.
Agreed. And then the slide you showed of multiplanar fractures.
Yeah.
I hadn't seen that slide before.
I was hiding it from you.
Right. So, which I think that really raised my eyebrows. So how do you think that plays into improving vessel compliance compared to, say, a non-compliant balloon or atherectomy?
Well, I think the example that I showed you of the concrete really can help, contextualize this. Because when you expand that balloon and you have multiple fractures in multiple planes, you're moving this and creating space in multiple different dimensions.
Right.
And that's how we can possibly improve vascular compliance. And this may be one of the reasons why the presence or absence of calcium fractures doesn't impact the minimal stent area or the stent expansion.
Right. Great points.
So on that note, man, you're up.
Oh, okay.
1 year data. I'm excited to see it. I know you presented it earlier, but let's see if this actually works.
Sounds good. We were battling over control of the mouse there behind the scenes. Thank you. All right, so I'm honored on behalf of my co-investigators to present the 1-year results from the Disrupt CAD-3 study, which examined the safety and effectiveness of IVL for the treatment of severely calcified coronary lesions. Here are my disclosures. All right, so Disrupt CAD-3 was a prospective, multi-center, single-arm global study that enrolled patients with heavily calcified de novo lesions with a reference vessel diameter between 2.5 and 4 millimeters and lesion lengths less than or equal to 40 millimeters. This was performed at 47 sites across the world. 47 patients were enrolled as roll-ins, and the ITT population consisted of 384 patients with 30-day follow-up, which was the primary results, which were presented last year. And I'll be talking today about 1-year follow-up, and 2-year follow-up is planned. And we'll talk a bit more in this session about the OCT sub-study and some really fascinating results that came out of that. The analyses that I will be discussing today are 1-year major adverse cardiovascular events which consists of a composite of cardiac death, myocardial infarction, or TVR. As a side note, the definition of MI differed whether it was peri-procedural or over follow-up. Around the time of the procedure, a CKMB level of greater than 3 times the upper limit of normal met the criteria of a myocardial infarction. And after discharge, we use the 4th universal definition of myocardial infarction. I'll also present the results of target lesion failure, stent thrombosis, and subgroup analyses, as well as predictors of MACE and TVR at 1 year. Patients to be enrolled in this study needed to have stable coronary disease without elevated biomarkers. They had to have a left ventricular ejection fraction of greater than 25%. And importantly, they had to have a single de novo target lesion. They had to be either severe by angiography or by functional testing. And they had to have severe calcification, which was defined as an angiographic radiopacity prior to contrast injection involving both sides of the arterial wall, train tracks on fluoroscopy. That was longer than 15 millimeters in length, or with intravascular imaging, there had to be calcium involving more than 3/4 of the circumference of the vessel. The lesion length, as I mentioned, had to be less than 40 millimeters. And there were some standard exclusion criteria as well. Here's the study flow and follow-up. So 431 patients were enrolled. Very rapid enrollment despite the COVID-19 pandemic. I think a testament to the clinical need of this technology. There are 47 roll-ins. The ITT population, 384 patients. At 1 year follow-up, 3 patients were lost to follow-up, giving a 97.1% rate of follow-up at 1 year. So good 1 year data. Here are the baseline clinical and lesion characteristics. Highlights, 40% of the patients had diabetes consistent with highly calcified lesions. More than 1 in 4 had significant renal insufficiency. The LAD was the primary target vessel. The lesion length on average was 26 millimeters, and the average calcified length was 48 millimeters, which is a testament to the high lesion complexity of the lesions enrolled in this study. Procedural characteristics. Ziad comments on this in our discussion that pre-dilatation was performed in about half of cases, but in half of cases it wasn't performed. So that I get a testimony to the deliverability of the catheter. Post-IVL dilatation was only performed at 20% of the patients. For protocol, you were required to do another dilatation if you did not have a 50%, if you had more than a 50% stenosis after IVL. So again, showing that IVL, despite these characteristics of the lesions, had pretty good acute angiographic outcomes. And stent delivery was successful in 99.2% of the patients. All the stents are post-dilated per protocol. Here were the early study results at 30 days, the primary outcomes of the Disrupt CAD3 study. The performance goals and study success were achieved with procedure success in 22.4% of patients and freedom from 30-day MACE in 92.2%, with very few serious angiographic complications, only 0.5%, despite the complex lesions treated. With excellent minimal stent area of 6.5 millimeters squared and excellent stent expansion at the maximum calcium site by OCT. Okay, so here's the 1 year results. MACE at 1 year occurred in 13.8% of patients. So there was a step up from 7.8% at 30 days to 13.8% at 1 year. In terms of the individual components of that MACE outcome, here they are. Cardiac death, quite infrequent. Target vessel revascularization, not surprisingly. Average lesion length of 26 millimeters. TVR went from 1.6% at 30 days to a very, acceptable TVR rate of 6% at 1 year. The MACE was really driven by peri-procedural myocardial infarction, which occurred early, obviously prior to discharge, with some small increment of spontaneous MIs over time. Here are the secondary endpoints. And let's focus a bit on target lesion failure, really only 11.9% at 1 year. Again, driven by target vessel myocardial infarction, which was predominantly peri-procedural. I just want to revisit this ischemia-driven TLR rates of 1 year of only 4.3% in a highly calcified subset of a set of patients with long lesions. And stent thrombosis, 1.1% at 1 year. Only one stent thrombosis occurred between 30 days and 1 year. Here are the MACE rates stratified by subgroups, a consistent treatment effect across all subgroups, with the exception of long lesions. You see a significant p-value where the longer lesions had a particularly higher rate of major adverse cardiovascular events compared to the shorter lesions, driven by non-Q-wave MI events and peri-procedural non-Q-wave MI events. If you look at 1 year TVR by subgroups, consistent across all of them. Here are 1 year outcomes, a multivariable analysis looking at predictors of 1 year outcome. And here, the things that fell out were bifurcation lesions, not surprisingly, prior MI and a current or former smoker, the usual suspects, really, and in terms of target vessel revascularization, prior myocardial infarction. So in conclusion then, the Disrupt CAD3 study at 1 year represents the largest and longest clinical follow-up of patients with severely calcified lesions treated with intravascular lithotripsy. Coronary IVL prior to DES resulted in a beneficial impact of IVL lesion calcium modification and stent expansion to at least 1 year. And the MACE and TBR rates were similar in almost all the subgroups analyzed, with the exception of long lesions, where 1 year MACE was driven by rates of peri-procedural myocardial infarction and a little bit of TBR. But further study is required to determine if IVL can effectively reduce longer term, that is greater than 1 year, adverse event rates, which we'll be able to look at our 2 year follow-up. So with that, I will make my way back to the group and we can discuss these results.
Come on back, Matt. So, interesting results. Let me start off with, the elephant in the room, and that is there's other calcium modification devices. There's orbital atherectomy, there's rotational atherectomy. How does this MACE rate compare and contextualize to what else is already out there?
Right, so I do think a limitation is saying it's a single arm observation, so we don't have a control. I think we talk about this, extremely difficult to do a good randomized trial. So I think a lot of these technologies are complementary, not one against the other. But the 1 year event rates, if you look at the MACE rates and the TBR rates, lower than that seen in the Orbit 3 trial. So completely, I think, acceptable. In fact, a 6% ischemic, or was it 4.3% ischemic driven TLR rate at 1 year in a lesion set of average length of 26 millimeters is pretty, testament to both the technology and drug evidence stents.
Yeah, that's these are some very complicated lesions. 45 millimeters of calcium, 27 millimeters long. Just to contextualize, most randomized trials, the lesion length is like 14 millimeters. They get 18 millimeters stents. So these are tough cases.
It's not an understatement to say this is probably one of the most complex lesions ever studied in a FDA registration prospective study.
All right, so I'm up next. And earlier you asked me about some of the unanswered questions, and I'm going to try to answer one for you.
Right, so you're going to speak about the pooled analysis of Disrupt CAD, looking at eccentric versus concentric lesions. Something I'm looking forward to seeing, because again, this has been really a question mark in terms of how to treat different types of calcified lesions with IVL.
Okay, so let's get cracking. And I think, this is one of the unanswered questions. Do you need it? How does it work in these eccentric lesions? Now, I think it's important before we start just to contextualize, there really isn't that many lesions that only have eccentric calcium, right? Most lesions that we see have a combination of multiple morphologies, but nonetheless, we do want to know how it acts on eccentric calcification. These are my disclosures. All right, so eccentric versus concentric, why does it matter, right? So I think this slide displays why it matters. Because you've got an eccentric, thick, less than 90-degree piece of calcium that's butting into the lumen, and here we put a biovascular scaffold in and it's underexpanded. Okay, that's the problem. It's pretty clear. And why does that matter? It leads to asymmetry that disrupts laminar flow. It impacts drug elution kinetics. It can lead to underexpansion, malapposition, and stent fracture. And the reason this is problematic is because the mechanism by which we modify these lesions is very different. So for example, here's an example of balloon dilation in a calcified lesion that's less than 180 degrees, that's thick. So as the balloon expands, the point of least resistance is actually the interface between the calcium and the wall, so it dissects it, right? So here you see a deep dissection from balloon angioplasty. And the eccentric lesions display higher degrees of recoil as a result of this. So let's go into the data. What we did here is we took all the OCT data we had from all the Disrupt CAD studies, and we looked at them very carefully, and you can see that we ended up with about 50-ish patients in each group. Less than 180 degrees, 180 to 270, 270 to 360, and then 360. And in this angiographic lesion characteristic group, I think the most important thing you'll see, and this is going to be a repetitive finding, is the more the concentricity, the more the calcium. Okay? It just makes sense. And so think about that in terms of substrate. The more the substrate, how does that impact the ability of IVL to make changes? So similar angiographic defined calcium severity regardless of the calcium angle, and increase in calcified length as the calcium angle increases. And so when we looked at the OCT, what you see is that the more concentric the lesion, again, the more the calcium, just like we saw in the angiogram. But now, rather than seeing on the angio, we can see this in 3 dimension and see that the maximum calcium angle increases, the continuous calcium angle increases, the mean calcium angle increases. And you see specifically there's a bigger jump between 180 to 180, 270 than elsewhere. And then, so ultimately, the more concentric the lesion, the more the calcium. And just like we saw in the examples, the eccentric calcium's thicker, right? Because it's focalizing into one side compared to the other. You're not spreading out the substrate. So here's the procedural characteristics to show you that they're actually very similar. Procedure time was the same, contrast volume was the same, your predilation was the same, and on as we go down this. There was really no statistical difference in procedural characteristics, and there was a numerical increase in pre and post dilation as calcium angle increased. But what this is doing is just really setting up the scientific hygiene that it's not a different substrate. We didn't treat them differently. They were all the part of one lesion. And, you know, they say a picture is worth 1,000 words, and here it is. And what you can see is that the impact of IVL in eccentric lesions is also calcium fracture. But remember that we have less calcium to work with. So the number of fractures we can actually develop is smaller. And what we're probably going to get in this, if I showed you earlier, if this was a balloon dilation, the mechanism is much more likely to be a dissection at the interface of the calcium with the fibrous tissue. And actually getting calcium fracture in eccentric lesions with a balloon is really hard. And really using IVL is the only mechanism by eccentric calcium that I've seen fracture. But as to maintain consistency with the theme, the more the calcium, the more the fractures. And here you can see that when we go to more concentric, so 270 calcium, we've got a couple of fractures. And then when we go to 360 degrees of calcium, we get in more fractures. So the mechanism of stent expansion in the concentric lesions and the eccentric lesions is different. In the concentric lesions, it's these multiple fractures that move away from each other like tectonic plates, yielding more space. But in the eccentric lesion, it may be a fracture coupled with more dissection, allowing you to expand. And this is shown graphically. The more the calcium, the more the fracture. And also, even when we normalize for the calcium burden, you see that the more the calcium, the more likely we are to fracture. This is the substrate answer. But interestingly, the minimal stent area and the stent expansion of the calcium site is the same. And so that's a little hard to contextualize, right? Like, why does that happen? Why isn't it better in eccentric? The reason is the mechanism of stent expansion in these different eccentric concentric lesions is different. You need less fracture when you have less substrate, and when you have more substrate, you need more fracture. But the bottom line is you're getting to the point at which you have greater than 100% expansion and your minimal stent areas are very similar. And you can see as a result of this analysis that it's a consistent minimal stent area and stent expansion regardless of visible fracture. Okay, so despite the fact that we had more fracture with more calcium, we're still getting a consistent MSA. What else do we learn? We learned that the visible calcium fracture increases, and it's the same jump from 180. Once we get to 180 above, it increases more exponentially. You can see that the fracture width increases because you need to make that space. You don't need to make the space in the eccentric lesion because you get a dissection, but when you're 360, you can't dissect it because it's calcified. So you need to kind of move those tectonic plates away from each other. So visible calcium fracture increases as the calcium angle increases. IVL use is associated with consistent improvement in stent expansion and luminal gain in both eccentric and concentric calcified lesions. There's no difference in any symmetry index analyzed by lumen and stent, and the increase in IVL-induced calcium fracture with increasing concentricity suggests that IVL induces vascular compliance through calcium fracture appropriate to need. I hope that made sense. It's a complicated concept, but I think it shows one of the unanswered questions, and Akiko's next.
I have one question for you before Akiko goes. So how should I apply these findings to my practice? So I do an angiogram, highly calcified lesion. What do I do?
I think the first and most important thing to remember is the angiogram still the gatekeeper, right? So if you have severe calcium on either side of the artery, the tram track appearance, that when you go in there and image it, it's highly unlikely that it's all eccentric, right? There's going to be multiple morphologies. Some is going to be 360, some 270, some 90, some not. But you should have solace in the fact that it's all going to expand. Because in the really tight, heavily calcified segments, Shockwave is going to break it and create calcium fracture. But it's still a balloon. So in the other areas where it doesn't need calcium fracture as much, it's still going to let you expand the stent. And the two, I think, most important messages is the mean stent expansion and the minimal stent expansion at the maximum calcium site. They're more than 100%. So it's working. So I think we shouldn't worry too much about the eccentric versus concentric because we get consistent results.
Can I ask, I don't know if my mic is on, can I ask a quick question? Have you looked at the number of pulses as it relates to the fracture? I mean, I don't know if you can come up with an index or something that would say, X number of pulses or because I think that comes to your questions like clinically, when you're in the lab, at what point do you say, enough is enough, or at what point should I, keep on going, right? So I think that's more of a procedural question.
It is a great question. Unfortunately, to answer that question, we'd have to deliver 10 pulses, then OCT, then deliver 10 pulses, then OCT, and we haven't done that yet, although some of us are crazy enough to do that.
Yeah.
But I think that what you bring up, Alexandra, is the concept of pulse management. Do you just dump all 80 pulses into the most calcified segment? I think the answer to that is no, because you can see that we still need to modify the eccentric lesions. So we should use our 80 pulses in the context of the ability of the balloon to expand, but use 10 pulses in the other areas of the 45 millimeters that are calcified in order to get modification in all of the calcified segment.
Right.
I cannot agree.
Yeah, and I wonder if there are any other metrics. I mean, we're going to hear from Akiko, but the thickness of calcification, the length of calcification, etc. I mean, all those things I think will be part of the future. I think in trying to understand how best to apply the treatment.
So next up is Akiko Maehara, my dear friend And this is going to be super interesting, okay? Because calcified nodules is one of the places where we kind of think, well, you got to cut it off, you got to get a haircut, right? and so this is fun. So Akiko, show us whether we need a haircut. I need one, but I haven't done it. So.
Okay, so I'm going to talk the specific for the calcified nodule. So we learn from the pathologist what is a calcified nodule is really accumulation of small calcium fragments which typically protruding to the lumen. And the underlying calcium is really thick and on the top, and when we look into the proximal distal, we see a lot of calcium plate. That's how it looks like the calcified nodule. And typically happen at the site of the bending portion of the artery. And this is a picture which we see by OCT and IVUS in the same case. And you can recognize small calcium fragments which accumulating and protruding to the lumen. And because inside there is a fibrin, and many times we see this type of very strong attenuation by OCT or IVUS. And pathologists call either eruptive calcified nodule or so-called healed calcified nodule based on the presence of the superficial endothelium. But in terms of the treatment standpoint, actually eruptive or nodular calcification really doesn't matter because we are treating the chunk of the calcium. But what is important is basement of the calcified nodule is really accumulation of small calcium fragments. So each individual calcium is actually small. And this is not the part of the CAD, but we ask the question, what kind of region having more likely calcified nodule? Answer is large arc of the calcium or hinge movement such as angle between the large angle between the systolic and diastolic, or the patient having the hemodialysis. So those are the predictor having the calcified nodule. And then when we look into the region which having the more than 270 degrees of the calcium, the prevalence of the calcified nodule is not there. It's about 30%. And then this is the data for the pooled CAD cohort. And it is not surprising we found the calcified nodule in 22% of the region because the CAD cohort having a lot of calcium behind. And then we ask, what is a predictor having the calcified nodule compared to without? Is one of the region-specific predictor was right coronary artery. This is also not surprising because always right coronary artery having the more hinge movement compared to the other segment. And then I would show something most important findings in the previous study because that's the point why calcified nodule is so important. And this is one case at Columbia. We see the very severe calcified nodule patient. This is after the rotor and balloon, you see the circumferential calcium. And after the stenting, actually we found the stent area is good. Minimum stent area is 6.6. And the patient coming back 2 months later with no STEMI. And you see this patient having the actually smaller stent area compared to before, meaning possibly stent fracture or stent recoil. And more importantly, inside of the stent, you see the calcified nodule again. So this type of phenomena we never ever see inside of the stent. Already 2 months later, we see the calcified nodule. And this also confirmed by the pathologist. They show in the autopsy patient, you can see the stent that is here, and this is calcium protruding to the lumen. So we don't see this type of the phenomenon, but that's what's confirmed by the pathologist. And typically, the clinical presentation is early in stent restenosis or recurrent in stent restenosis or coming back non-STEMI. That's often happen, and hemodialysis patient. And also important, this is a data from Japanese people. They show the very severely calcified region treated by rotor with without calcified nodule. Even though the stent area is big, the region which had calcified nodule had poor outcome. And this is a different paper from Japan. They also show similar findings, but more importantly, in this paper, they have the enough patients who had IVUS at the time of the event, and then they show 82% of the time, at the time of the event, there is a deep protruding calcium nodule inside of the stent. That's a big, big deal. And finally, this is also from Japan. They're picking up those tissue using the directional coronary atherectomy. And then they show by pathology, this is really the calcium inside of the stent. So those are the big questions which we really have to deal with in the clinical practice. So question was, what is the best strategy to deal with this very difficult type of the lesion? Okay, so then let's go back to the CAD pod data. And what we found, compared to the lesion without calcified nodule, minimum stent area is similarly good enough. And if we measure the mean stent area, meaning we analyze every 1 millimeter, and then average all together, and then we see that mean stent area is also good enough, meaning homogeneously, diffusely, even with calcified nodule, stent expansion is really good. And that's also true, even we ask based on the stent expansion compared to the reference segment, they are similarly good expansion, which we already see in the previous study. However, what I do think different by IVL compared to the previous study is this type of findings. So you can see so-called eruptive calcified nodule in the lesion, and after the IVL, in the lesion, I see the calcified nodule reduce. And what I see in the longitudinal picture, it seems to be the calcified nodule is reprotruding inside of the lesion. And then after the stenting, I see the calcified nodule almost disappear. So that's one findings which we see in the OCT. And the other pattern is looks like so-called healed calcified nodule, meaning I can see the surface on the top of the calcified nodule, already like smooth surface. However, after the IVL, they decrease, and then this longitudinal picture is very remarkable. You see, looks like the calcified nodule is again reprotruding, even though this is healed type of the calcium. And then after the stenting, I see the calcified nodule almost disappear and good symmetric stent expansion. However, that's not always true. This is a type of the cases. I see the very severe calcified nodule, and after the IVL and after the stent, looks like calcified nodule still there, and then just stretching the non-calcified nodule segment and making the stent expansion. So those type is quite different compared to the previous. But my thought was, compared to this type of the kind of the non-change calcified nodule, I see like reprotruding calcified nodule, I see more in the IVL compared to the other, meaning I don't have the direct comparison, but based on our very long experience, how calcified nodule react after the stenting, it seems to be different after the IVL, seems to be cracking the small calcium fragment and reprotruding in the region and making more symmetric stent expansion. And how looks like calcified fracture is a little bit different when we are talking the calcified nodule. Sometimes we see, but I don't think that's super important because calcified nodule itself is really small fragment of the calcium. But when we compare all together, actually when we compare the calcified nodule versus non-calcified nodule, we see more fracture in the calcified nodule region. The reason is not due to the calcified nodule, because the calcified nodule region should have more calcium everywhere compared to without calcified nodule region. That's the reason we see the more fracture outside of the nodule segment. Okay, to summarize, I think what is important is in the CAD cohort, we see the very consistent good stent expansion even with calcified nodule. But I think in terms of the calcified nodule, what is important is really long-term outcome. Can we see this good expansion at the follow-up? We don't know yet because we didn't connect the data in the CAD4 compared to the outcome. But based on the baseline data, I see the calcified nodule structure is slightly different compared to other cohort. Seems to be making more homogeneous and reprotruding the calcified nodule and looks like changing the structure. That's what we see in the CAD cohort. And finally, I think we see the more calcium fracture in the CAD cohort in the calcified nodule, but that's just like because more calcium. Thank you.
Okay, so I'm gonna put my vascular biology hat back on. And I used to think that all calcified nodules were basically this jagged crystal that stuck out of the artery wall that was the base of which was this massive plate of calcium. Now, I think it's like popcorn stuck in Jello,
Yeah.
at least 2/3. So you've got these little bits of calcium that are all separated, kind of connected with fibrous tissue. And when you do IVL and push it, it just gets pushed into the Jello.
Yeah, or like originally, as I explained, that's small accumulation of the small fragments. Each individual calcium is not super thick, it's small. So as long as you make the disrupt, they are getting like disrupt again, and then they are redistributed.
You just push it out of the way.
Yeah.
But here's the complicated part. Only 2/3 of them are like that.
Oh, wait a second. I think all of the defined calcified nodule should have the same structure inside. So should be all of them is small fragments. However, out of those, 3/3 can be disrupted, but 1/3 didn't. But that does not mean that calcified nodule is different pattern, but still a little bit hard compared to the other.
So you have this new data, right? And by imaging right now, it's hard for us to determine which is the popcorn and the Jello and which is the crystal. Is atherectomy better then? Or does it just matter that we've got the expansion? Like,
We don't know. We don't know. But I think when you do the atherectomy, yes, we can shape the calcified nodule as long as the wire bias in the correct location, right? But the most important, what is the most important in terms of the calcified nodule, what's happening long term? They are reprotruding. So I think the shaping a little bit, I don't know how help, but disrupt and then redistributed everywhere, I think the chance of the reprotruding theoretically should reduce. That's my opinion. And we really have to see the long term.
it's super. I read like 20 papers after they showed this data, right? And honestly, I'm like, should we just put a covered stent on it so it doesn't pop through the stent? I mean, like it's a completely new area of research. Anyway, I think it's increasing with statins, but that's a different story. All right, next up.
It also, though, I would say, we always saw these stents that come back. We said, "Oh, the stent wasn't expanded." That's during the index procedure. That's not true.
No, it's not.
It's not true.
It's not true at all. Okay,
Fascinating.
so
Thank you.
last but not least, Alexandra Lansky is going to talk to us about gender differences or sex-specific characteristics of IVL. So we're back to the clinical. Excited to hear what you have to say.
Thank you so much. I have to say, I love the energy and all the research that's gone into this. I mean, it's absolutely fascinating. So I'm going to switch a little bit and talk about sex-specific outcomes because I think it's very relevant to this conversation. Why is it relevant? Well, if you take a look at female patients with highly calcified lesions, you can see that the long-term outcomes after stent implantation are terrible. From this series, it's a large registry here from the WIN drug-eluting stent registry. Mortality is increased 38%, death and MI increased 48%, and the composite of death, MI, and target lesion revascularization increased 56% here in women with severe calcification. Now, other series looking at procedural outcomes with rotational atherectomy, what you can see is that the acute complications are much worse in female patients compared to male patients. So looking here at coronary dissections, a 4-fold increase in coronary dissections in women compared to men. perforations leading to tamponade, 5-fold increase in women compared to men. So this is a big deal. And of course translates directly into higher major adverse cardiac events and other outcomes, and presumably is part of the reason why we're seeing such poor outcomes long term. So, of course, the question is, what are the outcomes now with intravascular lithotripsy? And I think this was really a phenomenal, opportunity to be able to look at this. So what we did was a pooled patient-level analysis, including CAD1, CAD2, CAD3, and CAD4. And now we've heard about all these studies. Very similar inclusion-exclusion criteria, endpoints, adjudication, etc. We've looked at the 30-day major adverse cardiac events. Here, that was the primary safety endpoint, cardiac death, MI, and target vessel revascularization. And then looking at the primary effectiveness endpoint, again, procedural success, which was successful stent delivery with the residual stenosis of 30% without in-hospital MACE. So pooling all these patients together, we have 628 patients. That's a large cohort of patients, 22% of whom were female patients. So let's take a look at the outcomes. In terms of the patient characteristics, I think nothing too surprising here. The women tended to be older. They had more hyperlipidemia. They had more renal insufficiency, and fewer were smokers. Nothing really earth-shattering here. In terms of the angiographic characteristics, the vessels were similar, but I think, again, as we know, female patients had smaller vessel sizes. The pre-procedural diameter stenosis, so extent of disease and severity of disease, was similar between men and women. They had slightly more focal lesions, but still pretty diffuse. So 22 millimeter lesion length for female patients compared to 25. And again, really highlighting the fact that this is a cohort of patients with severe calcification. So no difference between men and women, but about 96% of these patients had severe calcification. So interesting, slight differences here in the procedural characteristics. Interestingly, men had more radial access, female had more femoral access. But in terms of the procedural time, was slightly lower for female patients. They had fewer IVL catheters, they had fewer pulses used during the procedures. Otherwise, if you take a look at pre-procedure dilation, it was similar between men and women, about 45, 48%. And again, per protocol, most of these patients received a stent, 99%, and post-dilation in the vast majority of patients. So here are the primary endpoints. And again, I want you to think about sort of the predicate and where we're coming from with the results from atherectomy in prior series. But what we see here is that 30-day major adverse cardiac events were exactly the same between men and women. Numerically, maybe a little bit higher in female patients, but no significant difference. So 7.1 in males, 8.3% in females. In terms of the procedural success, it was equally high in both men and women, 92%. So, and again, no significant differences. Now, when we take a look at the diameter stenosis immediately after IVL treatment, it was about 35% in both men and women, no differences. And once again, the post-stent residual stenosis is excellent, 11%, 11 and 12% in both groups. Some slight differences here in acute gain and MLD between men and women, but that is really mostly driven by differences in vessel size. So this is the important slide. So this is looking at the angiographic complications. So any serious angiographic complications, and again, this is all done by core laboratory, looking at severe dissection, perforation, abrupt closure, slow and no reflow, was 1.6% in female patients, 2.3% in male patients, absolutely no difference between the sexes. And again, I do not know of a series that has shown this previously. Obviously, post-stent deployment, there was no complications in females and very few in male patients. So this is looking at both in-hospital MACE and 30-day MACE and the components, just to point out once again that there are absolutely no differences here between men and women in any of these outcomes, whether you're looking at MI or target vessel revascularization at these 2 time points. And again, taking a look here at target lesion failure, no significant differences. Stent thrombosis, there were none in female patients out to 30 days. And again, no differences. So I think this series is important because, first of all, it's the largest series looking at calcified lesions with IVL therapy. I think it's telling us that the acute complications, angiographic complications, are excellent in both men and women, but particularly relevant, I think, based on the context in the female patients, so extremely low. And as we look at these outcomes out to 30 days, again, safe device and certainly effectiveness demonstrated post-procedure. So, and I think that's important to put in the context of prior atherectomy devices where we've seen very high complication rates. And I think along with some of the comments previously, I think what's going to be really important here is to look at these outcomes long term. So going out to 1 year and really trying to understand what the outcomes are. So thank you very much.
So how do we, I think what's clear here is that all of the previous studies looking at management of calcified lesions in female patients, they did worse. And here, there's no difference. That's like, it's a safety signal. So how do I?
It seems like it's the equalizer,
Yeah,
right? It's
right.
equalized in the patients that were selected in this series. It's really equalized the outcomes.
So why do you think that is? You think it's the microcirculation, the amount of heart, like?
I think, we've always said women have smaller vessels, and maybe that's the reason why we're seeing more complications. There may be more fragility in the female vessel, I don't know. But why are we seeing such high levels of acute complications, dissections, perforations? And these are severe dissections right after atherectomy. We've seen it after rotational atherectomy, orbital atherectomy, etc. So, I think there's a component there. It's difficult to tell, but I think that the mechanism of IVL here with, all the wonderful explanations that you had up front and the mechanism of action and the in situ fracturing of the calcium, I think is really, sort of a huge step forward, I think, in the outcomes of and I have to say, it's not just women. I mean, it's patients in general. So I think we're gonna, maybe a question back to you guys is the algorithm. How is this gonna change our approach to calcified lesions, right? Is this sort of a first line therapy and then, sort of selecting out some other patients maybe for more aggressive atherectomy? So maybe, what do you think?
If you just step back, there was no algorithm used in the study, and the outcomes were very good. So I think we like to think of algorithms when we have multiple technologies. Hey, what's it going to be best in? Nodular, eccentric, concentric. I think it's going to be very hard to do a randomized clinical trial of atherectomy versus IVL and nodular calcification. Particularly because all these things go together, which is a great, both of you showed that you don't have a lesion that's just eccentric or just nodular, very rare. So I think that it boils down to the fact you have a device that is sort of an all-purpose calcium cracker.
Yes.
Yeah.
Trademark that, please. So, and I think also that it does it in a way that doesn't expose the differential procedural risks or anatomical risks that you see, for example, in sex and gender, where when you're exchanging wires, when you're putting down burrs, when you're doing high pressure, non-compliant balloons, these expose differences among individuals, which can lead to differential procedural risk. So we don't see that because you go to 4 atmospheres with Shockwave. So I think it is sort of, it levels the playing field.
Well, I would like to thank you all very much for joining what was an exciting and energetic session. I think we have new data to show that IVL works in concentric lesions, eccentric lesions. It has no disadvantages in female patients, and we have very good 1-year outcomes. So thank you for Shockwave for sponsoring this satellite session, and more to come with the multiple registries and trials and the continued evidence base of Shockwave IVL. Thank you very much.